Sir, already one participant has raised their hand. Should
Yeah,
we
yeah, please,
give
please.
them the rights to talk?
Yeah, please, please. Anyone can talk, no problem. Hello?
Yes, he has.
Yeah.
Uh, yes, Dr. Gautam Mukesh, if you desire to talk, you can unmute yourself and talk.
Gautam? Yeah, take
Sir,
the
it was by mistake, sir. Sorry for that.
Okay. Right.
Good morning, sir. Very good morning, sir.
Morning, Umar. Good morning. We'll start in 2 minutes time. Okay, just wait.
Yes, sir.
Yeah, people are logging in. Just 2 more minutes.
Hello, sir. This is Joy.
Yeah, Joy. Good morning, Joy. Hey, good.
So one of the cases you discussed earlier, that
Yeah.
patient who we initially thought could be some neuropathy, and that patient had on MRI he had spinal AV dural AVF.
Yeah.
You remember that patient?
And a long back.
But spinal dural AVF was picked up only because MRI was done.
Exactly.
And is not suspected clinically.
Clinically, I did not.
That patient is sensory impairment was up to or more than the mid thigh. So would that clinical sign make us suspect that there could have been a correlation because his sensory impairment in the upper limbs was only till the below the elbow?
Yeah.
So we'd have expected the sensory signs in the lower limbs only up to the knee. So this sensory signs having reached the mid thigh, could it have been a point that the spinal cord was affected too?
Correct, exactly correct. You're perfectly right. But somehow or other, we did not think that maybe yes, clinical picture was something like a peripheral neuropathy. It's all reflex or absent, long durations. We thought something like a CADP like presentation. That is why we thought in that direction. Because the myelopathy was never suspected from the clinical findings. Findings are all predominantly LMN. Only MRI showed this long extensive hyperintensity. That never suspected clinically.
Okay, sir.
Can we start? Joy, can you start? Or wait for one more minute? Okay, we'll start with the Mansi. Shall we start now?
Yes, I'll share my screen.
Yeah, we can start. Okay. So, good morning, everyone.
Yes, sir.
The pattern is just like every week. This is the 11th, I think 12th session on these grand rounds. So I will start with the screen sharing. Okay, we'll go to the first case. I hope I'm audible. Okay. Now
Yes,
we'll
sir.
start the first case. Yeah. This is a story of a 44-year-old female who fell down from the bike and was admitted to the hospital for headache. On examination, there was no abnormality was detected. CT scan showed a small extradural hematoma in the left posterior fossa. Since it was very small, to state conservative measures and the headache improved. So this is the small extradural hematoma we found in the posterior fossa. I can show this is the one. Okay. So, however, on the fourth day, when the patient was about to get discharged, she developed severe headache and vomiting with aggravated at night. So examination again was with the normal limits, nothing abnormal could be found out. So we suspected worsening of the EDH, extradural hematoma, and the CT was repeated. This is the first one on the left side is a CT scan on admission. The second one on the right side is after 4 days when he developed the severe headache. This is the first film which you can see here. This is the second one. You can notice the abnormality there. The posterior pulse are corresponding on the side on both sides, before and after. This again another cut. So what will you do now? You can unmute yourself and speak. Try conservative measures. What do you think the patient is having? And what will you do now? Nancy, you can unmute anyone who wants to speak.
Sir, what about MRV venogram? Because the location, I feel, is it possible that the transverse sinus also rupture or something like that on the right side?
So you want MR venogram?
Yes, sir.
Okay, good thought. Now let us see the films once again. See, if you look at the film, the first film itself, which I have shown on the second, this one. See, there's a sinus thrombosis here. What Umar thought was correct. He had a sinus thrombosis. That was from the second one that was not present on the first one. And if you look carefully at the second, the film which I showed, the isodensity here is actually the old hematoma, which has become isodense as time passes on. What you find is an overlying long hyperdense lesion is actually the transverse sinus, as Umar correctly has thought. So the EDH has become isodense, and the long hyperdense area has come anterior to that. That is the transverse of sinus, which is getting thrombosed. So here, what is happening is that the trauma has precipitated the sinus thrombosis, because they injury to the sinus, and that can lead on to thrombus. If you look at the front spleen again, you can see the jugular vein is also getting thrombosed here on the right side in the jugular fossa. This is another film showing the transverse sinus thrombosis extending into the sigmoid sinus. So this is the MRI done, which shows a small extradural hematoma on the convex CT. You can find out the thrombus here, the sigmoid sinus, and the old ADH there. And again, you see the SWI. The large one on the anteriorly is the thrombus. The one posteriorly is the EDH. You can find the signal change anterior to that, separating the thrombosis and the old EDH. And this is the venogram showing the sinus thrombosis on the left side, on the right side. The same site as the extradural hematoma. This is because the trauma can precipitate sinus thrombosis. So there are certain risk factors in early diagnosis of CVT, secondary traumatic brain injury. There are 3 subtypes. One is a skull fracture crossing the sinus and epidural hematoma crossing the sinus with risk factors associated with venous sinus thrombosis. This is from the literature again. So any questions on this case? Because what initially I thought it was extensive, increase in the size of the extradural hematoma. But when you look carefully, only we found that there is a sinus thrombosis. Because of the same site as the trauma, as the previous EDH, just overlying that EDH. Any questions? Then shall I go to the next case?
Sir, was there any papilledema or something?
No abnormality. Absolutely no finding. Okay. I'll go to the next case now. It's another interesting case. It's a 54-year-old male patient with progressive walking difficulty for the last 1.5 years. In the form of dragging of the feet, buckling of the right knee followed by the left knee, probably buckling maybe due to weakness, maybe to some other things which you'll come to know later on. He needed support for walking for the last one. He had numbness of both feet initially, which improved in 2 weeks' time. No bowel or bladder complaints. So in summary, progressive walking difficulty, probably spasticity, had numbness which improved in between, and no bladder. In examination, high mental function scanners are normal. Motor system, there was spasticity of both lower limb. Power in the upper limbs were normal. Lower limbs were all grade 4. Reflex were brisk bilaterally both in the upper limbs and lower limb. Abdominal reflex were absent in all 4 quadrants. Plantar upgoing bilaterally. Sensations decreased posterior column, sensation below knee. This is the video of the patient, not a complete video.
Okay. മറ്റേ സൈഡ് ഓക്കെ ഓക്കെ നേസ്കോ റിഫ്ലക്സസ് സ്പാസം വിട്ട് ഞാൻ എഴുതുന്ന പ്ലാന്റ് കാൽ നീട്ടിക്ക്
Unable text.
CPS
Spasm goes up easily.
നീട്ട് okay to the plantar and see.
Okay, his plantar is upgoing bilaterally. The way he walks particularly with mild flexion of the knee. Okay, what is the diagnosis now? Anything clarification you want, you can ask.
Any neck pain or any limit sign?
No neck pain, no dermid sign. Only working. No complaints in the upper limbs or in the neck. Whoever wants to ask, can I unmute and ask this? No interest.
Sir, any weight loss or any systemic features of malignancy or
No
sure.
obvious system like that. Sorry, there is a one in there here. Okay. Any possibility? Anyone would like to voice out, please?
It's predominantly pyramidal tracts and posterior column.
Exactly. Perfectly right.
This could be combined.
Combined degeneration is a good possibility. But usually we don't find that kind of a spasm in there, but the spasms and maybe a spasticity like this, but they predominantly have a sensory ataxia, which was not very dominant in this case. And the angle jets are very brisk off.
Even paraneoplastic because tracts are involved.
Paraneoplastic is another possibility we have to consider. Okay, let us see. So whenever I get flexor spasms, first consider compressive myelopathy, because that's sign for monocompressive myelopathy. That's a classic thing. So what investigation you need now? Obviously MRI. So MRI dorsal spine, cervical spine is shown here, and dorsal spine is shown here. What you find is that there's no compression at all, but the cord is atrophied in the dorsal region. This is an axial section again showing the atrophy of the cord on the T1 and the T2. This is widened. Now, what possibility will you consider? Doesn't look like subacute combined degeneration. There's no compression, but cord atrophy. Your opinion? Or any investigation want now further?
So brain, sir, what about MR brain?
Brain was, I don't know, I don't remember how to have done. I don't think, because it clearly is spasticity with sensory loss. I did not think of a cortical. Plexus spasms indicate that patient has got a lesion in the cord. Plexus spasms, very extremely rare lesions above the median, if at all it occurs. According to the physiological mechanism, it should not occur above medulla, but I have seen one case, probably plexus spasm due to brain stem.
It's more like a non-compressive myelopathy, so we have to find out what is the cause, starting from the vitamin to the paraneoplastic level. So I think by examination and investigation, we have to find out.
So only investigation can prove the point, what you said is correct. But the thing what was troubling me was that I have never seen spasms in non-compressive. So compression, okay, process I have seen, either it is compression due to mass lesion or some other things. Okay, so these are the possibilities you have to keep in mind. As Uma said, topical paraplegia, Joyce said the CD paraneoplasty. These are the possibilities one have to keep in mind. Paraneoplastic and with selective tractopathies may be confined to the perimeter posterior column or combined. So the thing, second degenerative myopathy is that this thing, plexus spasm. So this is the investigation, blood investigation, 70 years or 72, and vitamin B12 was in the normal range. CSF 3 cells, protein 34, sugar 100. So what do you want to do now in this patient? Any other thoughts? Paraneoplastic workup?
Nerve condition studies, because I would like to know whether there's an additional new neuropathy also.
But how is it going to help you? We can think of a combined as a big combined patient. Nothing in the MRI and treated normal. Serum homocysteine should have been done, but it was not done because it was done. I mean, it was at a time when that investigation was not that easily available. Okay, let's see what happened. The CSF showed PDL was positive, FTAP was positive. So this case, we don't consider this entity, but whenever we think something presenting like a compressive myelopathy, but no other features are not fitting with, always keep syphilis as one of the etiology. Syphilitic spinal syphilis can take various forms. One is spinal meningomyelitis, that is syphilitic paraplegia, spinal meningovascular syphilis, spinal pachymeningitis, mimic cervical spondylotic radiculomyelitis, syphilitic gamma, and intimal syphilitic amyotrophy. They present something mimicking a neurologic amyotrophy. This is syphilitic paraplegia. No, actually, this is from the literature. Slowly progresses spastic type. It may have remissions or even arrest. Then they can have sensory involvement, but sensory involvement is always mild, and ARP is occasionally. Okay, any questions in this case? The learning point is that when you get a typical non-compressive myelopathy, you have to investigate thoroughly, think of odd or rare conditions. Anything, any comments or questions?
What is this? Pupils, how's the pupils, sir?
No.
No.
Look for it. Subsequently, there is no ARP, nothing.
Okay, sir.
No questions? So shall we go to the next case? Any questions from the audience? Okay.
So the peripheral nerve condition should have will help now, sir. It's a myeloneuropathy, and we can narrow down the diagnosis to syphilis also in case of myeloneuropathy.
No, syphilis actually it can produce taboparesis. It produces involvement in the posterior root that usually does not produce conduction abnormality. But if it extends downward, it can. But usually it's the radical posterior column is affected and the radicals are affected. But anyway, to diagnose syphilis, best thing would be a CSF, say serology rather than serology than the
Sir, initial sensory symptoms in the feet, sir.
correct.
Whether they are of myelopathy signs or what there is?
Myelopathy signs. Because
Okay.
subsequently showed a brisk reflex in this knee angle check when posterior column up to the knee. If a posterior column is lost due to peripheral neuropathy, we expect the leg to be lost.
Okay, sir.
Sir, what is the management in this case? Manage with penicillin?
Sorry, I forgot to tell you. But put on full course of treatment for neurosyphilis. He improved partially, but never fully at all. Even after 6 months, he was having left with spastic, but luckily he did not progress.
Okay, sir.
So the single CSF titer is enough, or we have to see any rise in titers to confirm it? or any other test is required to confirm neurosyphilis?
A series of VDRL is highly 100% specific for neurosyphilis, but it is not sensitive. Sensitivity is less than 50%. The series of FTA-ABS tests, the specific tests, are highly sensitive but not specific. So if we get a series of VDR negativity, that does not exclude neurosyphilis. But if it is positive, it is neurosyphilis. On the contrary, if the CSF FTA-ABS is positive, that does not mean it can be it's always due to neurosyphilis. But it is negative, we can say it is not neurosyphilis. So that is the difference between these FTA-ABS tests and VDR. VDR positivity means it is neurosyphilis. But negative does not exclude neurosyphilis. But here it is positive. And moreover, FTA-ABS is also positive. Any other question?
Yes, sir.
If you ask question, then only I will also learn from you. Because make me also think. So this 42-year-old male who is an old case of chronic liver disease, but not a diabetic, has presented with low backache for the last 7 months. 2 months back, he noticed ascending paresthesia from both soles, which ascended up to 3 weeks back, paresthesia both hands up to the mid forearm. 3 days back, noticed paresthesia of the anterior abdominal wall. 2 days back, noticed difficulty in getting up and buckling of both knees. This is the story of the patient. So, anyone want to make a comment about from the history? Looked like a peripheral neuropathy, starting from the lower limb and upward, subsequently motor suspension neuropathy. Only point is the low back ache was slightly odd in this patient.
Even the low backache could be part of a spasticity because this was followed by sensory symptoms as well as.
Yeah, but yeah, you can't think of a myelopathy. Yes, that's a possibility, but more like a peripheral neuropathy because paresthesia is confined to the anterior abdomen. So at that point,
peripheral neuropathy or radicular neuropathy because he has got proximal weakness.
That's good possibility. Let us see the finding in this patient.
ഇനി കൈ നെഞ്ചത്ത് വെച്ചിട്ട് ഈ കാല് പൊക്ക് മുകളിലോട്ട് പൊക്കിക്കാം ചോട്ട് നോട്ടെ 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 പാദം മുകളിലോട്ട്
ചവിട്ടിക്കോ
തള്ളകൊണ്ട് പൊക്കിക്കാം മുകളിലോട്ട്
മുകളിലോട്ട് പിടിച്ചോ തള്ളവിരൽ മാത്രം
ഇതും പിടിച്ച് റിലാക്സ് ചെയ്ത് കിടക്കണം.
Can't hear you properly, sir.
Abdominal reflex were absent. Can you hear me now?
Yeah.
Yeah. Abdominal reflex were absent. Both knee and ankle jacks were absent. Plantar was flexor. Very sensitive. that level when I stop, that upper limb sensations are all normal. So resulting
How do we test it?
joint sense and vibration were normal in the upper, but lower limb there is absent over the two. Is also different. You could get up from sitting. Now, on examination, KLS are normal. Motor upper limb tone power normal. Lower limb tone normal. Power gate 4, power of hip flexors, knee extensors, grade 4 plus power of dorsiflexors and plantar flexors. Slightly more weakness in the proximal muscles. Rest of the muscles were grade 5. DTR, the upper limb normal. The lower limb, both knee and ankle joints were absent. Abdominal reflexes absent. Plantar's mute. Sensation, upper limbs, all sensations normal. Lower limb, impaired pain up to mid calf. Impaired vibration joint sense up to ankle. Rhombox positive. Gait normal. So, what is your likely diagnosis of the examination? Think of
What about sensation in the abdomen?
sensation. The abdomen was normal initially. He said initially, that time it is normal. The first exam.
The first possibility is a peripheral nerve involvement. Both small and large fibers are involved with the component of radiculopathy in view of weakness of the proximal muscles of the lower limbs.
Okay. So you want to say radicular neuropathy in this patient? Agree?
Yes, sir. But the odd thing is upper limbs are not involved in spite of weakness of the proximal muscles of the lower limbs.
Even the abdominal fluids are also absent, still the upper limb fluids are present. That's actually odd.
But he complained of the paresthesias in the abdomen, no, sir. So can the cutaneous nerves can be involved?
You're perfectly right. He complained of paresthesia of the upper limb, but there on objective examination, he could not find any sensory loss in the upper limb, nor any reflex changes, nor any.
But I feel, sir, that the upper limb reflex are slightly brisker.
Yeah, I can take it. Okay, normal or brisk, whatever it is, it's well elicited.
But there is no spasticity in the lower limbs or upper limbs.
No spasticity. We also thought one like neuropathy, either axonal type of neuropathy or a radicular neuropathy in view of the flexors where axonal neuropathy, we expect distal muscle to be more weak. Here the lower limbs are slightly, proximal muscles are more weak, slightly more weak compared to the distal muscle. So it's radicular myeloneuropathy, like something like a CAD3. It's a possibility we have to keep it. So element weakness of proximal and distal muscles, the distal sensory loss, is a thing which we kept in mind. Is there anything odd? Not even a reflex in the upper limb, even though the abdominal reflex, even the abdominal reflex are absent. That I thought was odd, as somebody has pointed out. Can be caudate canine lesion. Very unlikely because it can produce lower limb weakness and sensory loss. But because we cannot get numbness in the upper limb or in the anti-abdominal wall, but that is not there on examination. So could it be an unrelated CTS? That also you have to keep in mind whether we are dealing with the numbness maybe with something else. But there are still many points out against cauda equina, for a symmetrical affection, absence of bladder affection, the involvement of all tools, and absence of acute pain. So most of the things are against cauda equina, but the back of the mind you have to keep that possibility since upper limbs are totally spared on examination. But keep that possibility. So what do you want now?
So still it could be a myelin.
Could be. Please ask again. Could be.
Sir, still could it be a myeloneuropathy? So upper limb sensation. He is complaining of involvement sensory symptoms in the upper limb with absent abdominal reflexes and the proximal weakness of the lower limbs. Can it be still a cervical myeloneuropathy, sir?
No, neuropathy is there, definitely there, but there is no evidence of the myelopathy at the moment. because absent abdominal fluid can be due to the radiculopathy or a neuropathy itself. That also absent abdomen can be due to LMN and UMN, whatever can be absent abdomen. To call myelopathy, we have no definite disc reflexes, no spasticity, no omniate plantar, but no evidence of any pyramidal involvement per se.
But the neuropathy can mask the pyramidal symptoms in the lower limbs, so the mute plantar and the absent reflexes.
You're perfectly right. But to produce a neuropathy, produce absent plantar with a normal power, what is more important is that the power should be 0 or 1. Here the EHL power is relatively good, about 4 to 4 plus power. Or even if it is 3 power, that is enough to produce an upgoing plantar. That associated neuropathy will not mask that thing unless sensations are totally lost. Totally lost due to an element weakness. But that's not the situation here. He's able to feel the sensation. He's able to produce a flexor plantar response. That means that flexor plantar response means that his sensation is like apparent arteries in that. To call that situation or to have a pseudo plantar like response, what you are referring to in a person with pyramidal lesion with associated peripheral neuropathy, the plantar may not be upgoing. What you said is correct. In that case, the EHF should be significantly weak due to an element, but that's not the situation here. So that explanation we cannot attribute for an absence of plantar. You understand?
Explain the back pain was. Yes, sir. Understood.
Okay, thank you.
The symptom of back pain, sir, is complaining. You're not localized what is the cause of the back pain.
That I don't know. He complained of back. That's the story he gave. Sometimes the GBS patients also complain of back pain and diffuse pain. They complain of. They can also complain of radicular pain. I've seen backache in GBS.
Sir, in this case, the predominant symptom he has got sensory symptoms in the upper limb, lower limb, and the anterior abdominal wall with mild weakness and loss of reflex in the lower limb. So could that be just a post-column myelopathy, like some because since it's CLD?
Yeah, the way you think is correct, but the only thing is it's not lesion is not in the posterior column. If it's a posterior column, why should the knee and ankle joint should be lost? So if you have to think in neurology, first we have to localize. Once you localize, then only go for the second step of etiology. But you are thinking of hepatic myelopathy is a good possibility. Hepatic myelopathy is NDT. Even hepatic neuropathy can also occur. NDT where the predominant pyramidal tract is affected in hepatic myelopathy with less, if at all, sensory involvement. That's classically in hepatic myelopathy.
Sir, to consider CADP, sir, the sensory symptoms are more than the motor symptoms, sir. With the predominant involvement of low limbs and not involving the upper.
Correct. You're right. Sensory symptoms are, but sometimes some of the sensory CADP can various variants. Some CADP can be purely sensory. So that's an uncommon presentation. But what you said is correct. There are odd points for CADP. Most is yeah, please.
And the history wise, sir, he had complaints for 2 to 3 months and rapid worsening over last 1 week to 10 days. Can it happen in CADP, sir?
Yeah, of course it can happen. CADP is a condition where it can have progression or remission relapse or relapsing type. Any types can remain static and worsen. Okay, now let us see the investigations. So this is the NCV. The upper limbs are normal. There is no motor. This is motor conduction. The lower limb, the only abnormality found was a decreased CMAP amplitude in the left component. Those other muscles which are affected were not, did not have a decreased CMAP. FA latencies were normal. And sensory potential is also normal. When mild prolonged the distal latency in the median, you can ignore it because it may be unrelated competent. So in a sense, his nerve conduction study was normal except for a decreased CMAP amplitude in the common phenomenon. Whether it's technical or something, we don't know. But TVL was normal. Now, what do you think? No sensory. But findings say sensory was involved. Your particular result is correct. Very correct. Rhombus is also positive. His complaint was sensory. Now, what do you think is likely to be possible?
The screening of cervical to rule out any cervical involvement, sir.
No, do not deviate. I think even if conduction is normal, try to explain the normal conduction with the clinical possibility. Because myelopathy, we said, okay, possibility you can consider, but how to explain the absent reflex? How to explain the distal symmetrical sensory loss? And then that it's a little odd, no?
Sir, if there is a posterior root or posterior column in involvement, you would expect DTR loss also, because
posterior column, you will not get DTR loss. Posterior root, yes. To have a reflex loss, lesion should be in the reflex arc.
Yes, sir. Okay.
Sensory ganglion, posterior root, inside the column or in the anterior constant and different. Not in the posterior.
Okay.
So radiculopathy is
there's a radicular involvement.
Yeah. So you could get
radicular involvement. You can explain the NCS findings except for the F waves.
F waves, but F waves may not necessarily be lost, because what we are measuring in F wave is the F wave latency. In fact, normal conduction, we don't look for the chrono dispersion or the persistence. We are not looking. Chrono dispersion is ideal for demyelination. But what Joy said, if you had a prolongation of the F wave, it is well and good, but need not necessarily be prolonged. Why? Because suppose imagine 10 fibers are there in the root, 10 fibers. If only 2 fibers are preserved, normal, FA latency is normal. Only to produce latency abnormality, all fibers has to be affected in the nerve, at least to some degree. Otherwise, FA latency may be normal. Because what is measuring is not the dispersion in the FA. We are only measuring the latency, minimal latency. So if 1 fiber or 2 fiber is preserved in that posterior root, FA latency becomes normal. So that's a pitfall in that. If it is absent, that's a good thing. We can be definite. If it is normal, that does not exclude a posterior root. Not posterior root, anterior root. Okay.
CSF.
Yeah, okay, we do this perfectly right. CSF was 61 milligram per deciliter. No cells. So you want MRI also? Okay. MRI, cervical spine normal, dorsal spine normal. Ammonia was 140, fasting blood sugar normal. What else you want to do?
LFT and UST abdomen.
That showed he's got a cirrhosis.
So B12?
B12 was normal. That picture was also
in MRI of the lumbosacral spine with contrast.
Your point is correct. You ruled out a quadricular illusion, but we can't explain the abdominal layer plus loss in this patient and sensory loss and combines the upper limb. That becomes very odd. And anyway, they can keep that possibility. I don't know whether it was done or not. Must have been done. I don't remember to have seen the MRI. The B12 level was normal.
So this case of VDRL, sir?
This is VDRL. Sorry, but predominantly peripheral neuropathy, no? So I did not consider a syphilitic.
LFT?
LFT was abnormal. LFT was, I showed the ammonia was high. LFT is CPT, I will show the CPT also. CPT, the protein was like this. SCOT was, AST was 243. So the diagnosis is, we are not deviating the diagnosis. The diagnosis is CASMB. CASMB means it's predominantly affecting the root, which can produce motor weakness as well as sensory. The motor weakness manifests only as decreased hemipambic because anti-root is affected. But sensory potential will be normal because lesion is dorsal to the ganglion. You understood? So this just like a CASP. In CASP, it is a chronic inflammatory sensory polyradiculopathy. That means only the sensory roots are affected. It mimics ganglion neuronopathy, exactly like a ganglion neuronopathy. The only thing is that ganglion neuronopathy sensory snap should be absent or decreased. But in CASP, the sensory potential will be known because lesion is the proximal to the ganglion. In CASP, you can even find hyperintensity in the posterior column because of the retrograde degeneration. Because from the central process, neurons on the dorsal ganglion go to the posterior root, ascend in the posterior column. That can degenerate. Even hyperintensity can occur in the cervical cord even. But the lesion is maybe. The clue is that in radiculopathy, reflex will be absent. Whereas if it's a posterior column, reflex will be present. Why is not CASP alone? Because the motor weakness is there. CASP should not produce motor weakness. So it's got a possibility we consider was CASMP. So I put the patient on IVMP. He improved remarkably initially. Then I subsequently switched to Medrol, major production tablet. He worsened again. So 2 weeks later, he came back with worsening. And this is the finding now. He has only weakness.
ലൂസ് ആക്കിയിരുന്നേ അല്ലേ
ഇങ്ങനെ കുത്തി വരുമ്പോൾ ഇതിന് വ്യത്യാസം ഉണ്ടെങ്കിൽ പറയണേ, ശ്രദ്ധിച്ചിരിക്കണേ. ഇവിടെ കൂടുന്നുണ്ട്, കൂടിയ ഉടൻ പറയണം. കൂടുന്നുണ്ടാവും. ഇനി എന്തിന് വ്യത്യാസം ഉണ്ടെങ്കിൽ പറയണം. ഇവിടെ കൂടുന്നുണ്ടാവും, ഇവിടെ കൂടുന്നുണ്ട്. ഞങ്ങൾക്ക് കിരികിരിപ്പ് ഇതോ ഇല്ല. ഇപ്പോഴോ ഇത് അതറിയാം.
Reverence is now embedded up to the anterior iliac spine. Anterior spine is able to appreciate, but not in the knee or the. So both hand grips become weak. Second examination. Impaired pain over the anterior abdominal wall. Impaired vibration up to iliac crest. First of the findings remain the same. Now, anything you would like to consider? This
Sir, he has a sensory level around D7.
Correct. Yeah.
So that would favor an additional myelopathy, though there is no evidence, no clinical evidence to say that there's a myelopathy, but the examination wise there is a sensory level.
Now, the point you have to say is very correct. When you get a truncal sensory level, remember this point. You always have to think of the myelopathy. It cannot occur with the patient. But that is why I did the second examination. Did you know what I do? I did from the midline laterally. He is able to feel up the lateral part of the abdominal wall. It is lost only in the anterior abdominal piece. And that is classical peripheral neuropathy. In peripheral neuropathy, sensory loss occurs in the distal most portion. That is near the midline in the abdomen. and that be V pattern. V pattern in the sense it be more lower down than the upper part because the longest this the intercostal nerves take a slant downward. So it become not exactly just like peripheral, you get exactly in a statement like this, like a V pattern. That's exactly what this patient had. So the apparent sensory loss, let's say level, was only because the V pattern has become disappeared. So in such a case, always look for sensory level trunk on the back of the trunk. In the case of peritoniopathy, you will not get a level in the back. If you get a circumferential loss in the back, also it is decreased. There's a level. It is myelopathy. Did you understand my point? Because if the person has a coming posterior like that, the first area to have sensory loss will be the anterior abdominal wall. And that will be like a V pattern because the longer the nerves, the first to be affected, most to be affected. So the lower undercourse, like a longer course, they'll be affected first. And there will be more loss in that nerve than in the upper part. These have become shorter nerves as it goes upward. That is why you get apparent sensory level in peripheral neuropathy if you only examine the anterior part of the trunk. So always in suspected case, look for the posterior aspect of the trunk. I check the posterior aspect, there is no level in the posterior part. Even the lateral part of the abdomen is able to feel. If you see that, I took it laterally, the same level where it's not feeling, taking it laterally is able to feel. That means it's only confined to the anterior abdomen. So it is peripheral neuropathy itself.
Sir, any component of mononeuritis multiplex, they can have like this pattern in the anterior abdominal walls?
Yeah, of course they can have. Because it only indicates if in mononeuritis multiplex in the sense that if, it has to be distal involvement. The dying back like phenomenon should be there. Then only get this kind of a pattern. In axonopathy, what is happening is the longest nerves are affected. And the longest means the distalmost part of the nerves be affected first. That is why it starts in the feet, the toes, then the feet, then the angle like that goes up. Similarly, in the case of intercostal nerves, the longest, the distalmost part is the anterior abdominal region. As it progresses progressively, it involves other things. So in a single intercostal nerve, you will not get that pattern. That will lost everything. That segment will be lost. Because intercostal nerves has not a plexus. So it will be nerve loss will be like a segmental loss. Only patch of sensory loss will be there. But this pattern can occur only a distal axonopathy affecting the intercostal nerves. Or dying back phenomena should be there. Okay, so what I did, the repeat conduction now shows that the peroneal potential remain decreased, and now the sensory potential has become lost. The soul will become initially insatiable, now become absent. Now what is the diagnosis? Diagnosis becomes very simple. Now it's become CASMB has now become CAD. Now the diagnosis becomes easy for you. Because the sensory potential is also lost. Now you know that lesion is distal to the ganglion. So what will you do now? So put the patient on steroid along with mycophenolate. In 2 months' time, after I started tapering of the steroid, it's only on mycophenolate. This patient has may follow up for last 1.5 years, no further recurrence. Perfectly normal, reflexes come back, sensory has disappeared. It's otherwise good, except for that he occasionally consumes alcohol, goes back to hepatic failure, comes back. Other than that, is neuropathy, but is perfectly all right.
Sir, in that case, you started him on steroids initially. Initially improved, then later he worsened. So what could be the mechanism for that?
Because
worsening
also was not adequate. Initially, I gave IVMB, high dose of steroid. Then I put him on, I thought it may be monophasic type of thing, we can improve. Started reducing the dose of steroid, then worsened. So I cut the steroid, then as a steroid sparing agent, put on mycophenolate. Okay. That high dose steroid and mycophenolate continue for some time, and then steroid is gradually tapered off. Once the mycophenolate is taken its effect. Just like do any demyelinating polyneuropathy. Because initially tapering did too rapid tapering was that is why he worsened initially.
Sir, was evaluation of paraproteinemia done in this case, sir?
The paraproteinemia was not done.
Sir, is it possible that this could be a lower limb variant of the CADP, which later turned out to be a...
What is it is correct. It's a lower limb variant of CADP. It is presented like a CASMB or CASP like presentation, then becomes CADP. So the lesson I want to tell you is that finding a normal conduct initially do not exclude the possibility of CAD. But it may become abnormal later on. That's the point you have to keep in mind.
That's great.
Another thing you remember that, see, when Joy was telling, see, in CADP, the lesion is in the roots of proximal part, where your sensory conduct will be entirely normal. If it is a demyelination, unless the axons are lost in the distal part, you won't get absent snap. See, demyelination, imagine a total demyelination of the root or the proximal nerve. Your snap will be normal because you're stimulating distal to that block. Patient has sensory loss because sensory conduct complete conduction block. But you are stimulating distal to that and you can snap now. Unless its axons are lost, snap will not be affected. Or you should have a demyelination in the distal part, distal to your point of stimulation. So absent snap does not mean that the patient has got the lesion is not in the distal. You got the point. It should be severe enough to present the axon loss. Am I clear to you? Am I made my point clear?
Sir, in this patient.
Yeah.
Sir, in this patient, sir, that sensory symptoms initially, they are typical of axonal neuropathy, not like something demyelinating neuropathies.
Correct. That's also correct. You know what you said is correct. It is like an axonal neuropathy in this patient, clinically in history-wise. But actually, the patient was like a demyelinating pattern. There are sometimes a demyelinating neuropathy can also produce a distal symmetrical pattern of involvement, like what the variant called DATS variant. DATS variant of demyelination produces only distal symmetrical sensory involvement, mimicking an axonal. So that it only shows that the demyelination is not a distal, not proximal.
Okay, sir. Thank you, sir.
Okay. Any other questions in that patient? Okay. Now come to the next case. The 65-year-old diabetic lady was admitted 1 week back with right MCS stroke with left hemiparesis, from which patient was improving. However, for the last 3 days, she gets episodes of decreased responsiveness, apathy lasting for 5 to 10 minutes, 5 to 8 minutes. During this episode, patient had to be repeatedly coaxed to get an answer or follow any command. As you like a zombie-like behavior. The response partially, somebody may not respond. I'll show the video of the patient. Here, stroke was 1 week. Okay, 1 week back. Now, this is the presentation.
അങ്ങനെ ഒരു അമ്മ പേര് പറഞ്ഞമ്മ പേര് പറ എന്താ അസുഖം പറ ഉറക്കെ പറയാമോ എന്താ അസുഖം പറയമ്മ തലവേദന പിന്നെന്താ വിഷമം പറഞ്ഞോ പറയാൻ നോക്കിക്കേ ശ്രമിച്ചേ നോക്കിയെന്ന് പറഞ്ഞോ പിന്നെ പിന്നെ ഇനി വലത്തേ കൈ പൊക്കിക്കേ ഇടതേ പൊക്ക് ഇടത്തേ കൈ പൊക്കമ്മ അമ്മ ഇടത്തേ കൈ പൊക്ക് ഇടത്തേ കൈ പൊക്ക് ഇടത്തേ കൈ ഒന്ന് പൊക്കിക്കേ വലത്തേ കൈ പൊക്ക് ഇനി ഇടത്തേ കൈ പൊക്ക് ശ്രമിച്ചേ അമ്മയുടെ ഇടത്തേ കൈ ഏതാ എന്നെ നോക്ക് വെച്ചോളാം തോർത്ത് വെച്ചോളാം അവൻ ഇങ്ങോട്ട് നോക്ക് എന്നെ നോക്ക് അമ്മ
I'm asking which is left hand. Now she is able to point it out. Initially, she did not point out.
തള്ളവര എവിടെ തൊട്ട് കാണിക്കും തള്ളവരിൽ എന്ത്
Ask him to point
തള്ളവരിൽ തൊട്ട് കാണിച്ചേ
the left side.
തള്ളവിരൽ തൊട്ട് കാണിക്കാം. ആ
pointed
ശരി
that
ശരി.
out.
ഇനി ഇടത്തേ കൈ കൊണ്ട് അമ്മ ഒന്ന് മൂക്കെ തൊട്ടേ. ആ ഇപ്പം കുറച്ച്
Ask your
ഇമ്പ്രൂവ്.
left ear,
ഇനി ഞാൻ എന്നെ നോക്ക്, ഇങ്ങനെ
slightly
കാണിച്ചേ,
become better now.
ഈ കാണിക്കുന്ന പോലെ കാണിച്ചേ. ആ ഇനി മറ്റേ കൈ കൊണ്ട് കാണിച്ചേ. ആ ഇനി അമ്മ ഒന്ന് നടക്കാൻ നോക്കി, 1 മിനിറ്റ് നടക്കാൻ നോക്കി.
Make the walk.
എഴുന്നേക്ക്, 1 മിനിറ്റ് എഴുന്നേക്ക്.
Continue to do what I was doing.
എഴുന്നേക്ക്. ശരി, ഒന്ന് പിടിച്ചോ പിടിച്ചോ.
Keeping your hands like that.
ഇനി അമ്മ അവിടെ വരെ നടപ്പെങ്ങനെ കാണാൻ
Support to make this stand.
നടന്നേമ്മ. ശരി, മതി മതി. അമ്മ തിരിച്ചു വാ, തിരിച്ചു വാ, തിരിച്ചു വാ അമ്മ, തിരിച്ചു വാ അമ്മ, തിരിച്ചു വന്നേ. അമ്മ അവിടെ
Look at your face and
അമ്മ ഇവിടെ ഇരിക്കമ്മ, ഇരിക്കേ.
now see what's happening.
ഇനി നേരം നോക്കിക്കമ്മ.
They become all right now.
പേര് പറഞ്ഞു ഇനി. ആ എവിടെ വീട്? പോയിട്ടുകള. ഇതാരാ നിൽക്കുന്നേ? മോൻ. ഇനി ഇടത്തേക്ക് പൊക്ക്, ഇടത്തേക്ക് മൂക്കെ തൊട്ടേ. ശരി, മതി.
Okay. What do you think about that condition?
So this could be a non-convulsive status, maybe NCS.
Non-convulsive status. Yeah, correct. With complex auto.
With complex. The second possibility could be that she is getting a watershed, something like a hemodynamic stroke. I mean, getting a recurrent flow decrement, probably due to a proximal stenosis in the carotids or in the MCA. These are two of my attention.
Yeah, one always has to keep them in NCS because in non-convulsive patients, they don't have total loss of awareness. Here also, patient don't have total loss of awareness. So only Tumbi like responding at times, sometimes does not. That's well known with the non-convulsive status. So, any other opinion? So, what do you like to?
Attacks of TIS, short attacks of TIS can be the first possibility. So in view of partial responsiveness, she is able to have eye contact and she is able to follow commands sometimes during the attack also, which do not happen in complex commercial seizures.
What Umar also said, personally, I wouldn't consider TAA because I'll tell you the reason why it's not TAA. TAA, you will, in hemispherical TAA, will not get transient loss of awareness. Here it is akin to a partial loss of awareness. She is not responding to my question all the time. Like a zombie, like I have to tell 10 times I have to ask a patient to get an answer. That will not occur with hemispherical TAA. That occur with a seizure. So TAA seems to be unlikely in this patient. More likely to be the possibility of a complex partial non-convulsive status or recurrent seizures.
Would it be a thalamic syndrome which causes
thalamic syndrome also can produce a confused behavior like that. But the only thing is it's a paroxysmal event. Here it is complete. You remember last part it became totally. And after some time these things repeats again. So what did you want to do now?
I will do EEG.
EEG was normal.
EEG, or injection lorazepam in case of when she gets that symptomology again.
Yeah.
Give a 4 milligram of benzodiazepines.
Yeah. Okay, what you said is correct. But only thing is even lorazepam make the patient drowsy. They will not know whether it's due to the disappearance is due to that lorazepam or seizure.
So doing a video EEG at this can give you the clue and also monitoring the RBS sugars during the attack.
Correct. That's the thing I wanted. Say patient was already on 3 eptoin and 3 CM before he on this medical scheme. So what do you want to do now? And blood sugar is 245 milligrams. So you know what I did? I stopped all anticonvulsants, put the patient on 4 pints of normal saline. Everything had subsided next 24 to 48 hours, and everything subsided. So this, what is the patient had been having is hyperosmolar non-ketotic cough. Then you may ask why the blood sugar is not that very high. Take it from me, out of my experience with it, blood sugar need not be very high to diagnose hyperosmolar cough. If you get paroxysmal seizure-like phenomena, last time I showed one case where blindness, episodic blindness on one side of the visual field due to hyperosmolar state, cross behavioral abnormalities from more focal conversion. Blood sugar need not be very high, maybe like this range of patient good with normal. So what the patient had was hyperosmolar state, producing a recurrent seizure-like phenomena as summarized, something like a non-convulsive phenomenon. But the etiology was high blood sugar. Not high blood sugar, high osmolality. We are not checking the osmolality usually. We only check the blood sugar. So blood sugar.
So what are the any ketosis, or in this case ketosis?
No, usually there would be ketosis hyperosmolar state. Non-ketotic hyperosmolar state.
Okay.
Sir, the more common is choriothetics than the complex
Yeah, you're right.
partial. So
There can be hemobiolism, there can be choriothetosis, there can be intestinal another peculiarity of hyperosmolar state is that they can focal motor convulsions, which may not be present at first. The patient is asked to lift up the arm, then they'll get the jerky movements. I got another video of that patient. If you want, I can show the lip time permits there, where the patients get these things. Shall I show that video if you are interested to find out intentional seizures for the hyperosmolar state?
Yes, sir.
Yeah, just I will minimize and then take that thing. Okay, I have to stop.
it's a metabolic phenomenon or a seizure phenomenon, sir, finally?
This was a seizure phenomenon. I'll stop share for the time being, but to search the other one.
So the EG is normal in this patient.
Yeah,
the reason, sir?
most of the time hyperosmolar state, EG can be normal. Check out that.
Can't it be a transient encephalopathy? So if EG is normal.
Yeah, you can call it episodic phenomenon. No, if a patient becomes perfectly normal in between. Now I'll start sharing this screen. Can you see my slide?
Yes, sir.
Yeah. So look at this video. This elderly man repeated jerky involuntary movements for the last 3 days. These movements used to occur many times, mainly whenever he attempted to move the lip. See the video of the patient. These movements. Cannot do that. You cannot reach my finger. Sideways without his any movement.
Sir, is it something like myoclonus or balism like thing?
Right. You can call it some repeat myoclonus only. Again, ask him to touch my finger. The hand goes into repeated stereotype myoclonic. But The moment is getting quiet, it will disappear. Trying to attempt to move the limb, it's again putting back, it disappears.
Something like a monobialism, sir.
Yeah. So it's only just to show that. This is said to be very characteristic of diabetic hyperosmolastic. I'll go back to my previous one. Okay, you can see my slides now, no? Okay. Are you able to see my slides? No.
Yes, sir. Yes, sir.
Can you see this one? Okay.
Yes.
Right. Then I think I will go to another case. This has been shown to some of you. So I'll go to only time is getting short. Let's go to this one. This 6-year-old child had fever 2 weeks back and fond of upper respiratory infection. She did not go to school for 1 week. When she went back to the school, she was noticed to turn her head to one side whenever she was reading or watching TV. That is the complaint. The old female had fever 2 weeks back and had upper respiratory infection. She did not go to school for 1 week. When she went back to the school, she was noticed to have turned her head to one side whenever she was reading or watching TV. This is the girl. You can see what is, look at the eye movement. Ask her to read what's happening to the right eye. Ask her to look up. Looking up. Look up again. Left eye is going up, right eye is not going up. The left side, right, up and down. Left up and down, left up and left up. This is the left up and down. See what is happening with the right eye. Left up and down. Left up and down. Okay. Any thoughts? What did it say?
Predominant right eye is affected, sir. Where there is a right upward gaze paresis is there, and she is having downward spasm when she turns to the other sides.
Now, if you want to see the video once again, I can show. You're satisfied? The findings first. Let's see the finding. On ask you to the right.
Show it again, sir.
Yeah, I'll show it.
പറഞ്ഞപോലെ ചെയ്താല് അച്ഛൻ മുട്ടായി വാങ്ങിച്ചു കേട്ടോ മുട്ടായി വാങ്ങിച്ചു
Sir, it seems there's a right inferior oblique palsy.
Another bit
ഇവിടെ നോക്കുമ്പോളെ ഇവിടെ നോക്കിക്കേ ഇവിടെ 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 നോക്ക് ഇവിടെ നോക്ക്
Okay. Now you can tell me, but what did he say?
Right inferior oblique, sir.
Yeah, right inferior oblique palsy is very good thought. Any other possibility would you like to consider? Anyone?
Superior oblique tendon sheath syndrome.
On the right side. Very good. Then
Kala.
Any other possibility? What both of you said is correctly, what is said is correct. Two possibilities, what is called a Brown syndrome, that is superior oblique tendon sheath syndrome. So there is inferior oblique paralysis. Both will produce almost the same phenomenon. No, it is not a gaze palsy because for gaze palsy, it's a conjugate palsy. If only one eye is not moving, don't call it as a gaze palsy. It should be symmetrical involvement in gaze palsy. So it's not a gaze palsy. What you said, the other thing is that on looking down, there is pulling it down. Okay. On adduction of the, on looking to the left side, when the right eye is adducting, the right eye goes down. You know, I will show the one.
No, they got some other.
ഇവിടെ നോക്കുമ്പോളെ ഇവിടെ നോക്കുമ്പോളെ നോക്കുമ്പോളെ ഇവിടെ നോക്കുമ്പോളെ
And show that. So this is the position. Patient looking the left side, the right eye is going down. If that should occur, two things should be happening. One, on looking at the adducted position, the muscle which are making the conduct is a medial rectus. But in that position, if one of the inferior superior oblique or inferior oblique is weak, the other thing will overact. Suppose imagine that in the adducted position, the inferior oblique is weak, which is an elevator. That is weak. The superior oblique is elevated that pull the eye downward. So that can occur due to the overaction of the right superior oblique or weakness of the right inferior oblique. These two things are present. So what happens in Brown syndrome is that because of the restrictive ophthalmopathy, the inferior oblique is prevented from acting. In a sense, it's like a inferior oblique palsy. So for any agonist to contract, the antagonist should relax. For example, I tell you, on the right eye, if my right eye nerve rectus has to abduct my right eye, the right middle rectus has to relax or get inhibited. If it is preventing that relaxation, what will happen? The right eye cannot abduct because this fellow is pulling it. This is a restrictive ophthalmopathy. Something similarly, for the inferior oblique to produce elevation, the superior oblique should relax. They should relax. But that is prevented from relaxing because of the restriction in the superior oblique. The inferior oblique cannot elevate that. That is what is called the Brown syndrome. Another possibility, as Umar said, is inferior oblique palsy. It can behave exactly the same, where it's a palsy. Now, how to differentiate both the things together? Whether it's an inferior oblique palsy on the right side or it's Brown syndrome. There are 2-3 points which I will tell you later on in this. Now, the other condition.
So one question, so one doubt. Why should the inferior oblique overact when the eye is supposed to look upward? Because neurons in the inferior oblique is not supposed to fire during upward movement, no?
No, inferior oblique is an elevator. Inferior oblique is an elevator, no?
No, why should the superior oblique should overact when this child is trying to look upward and to the left?
Because just like the contracts are producing, for example, esotropia due to lateral rectus palsy, the other fellow will overact. See, in the case.
Now, why should it overact? Because the brain is sending impulses only to the muscles which are supposed to look upward, no?
No, it's not like that. Normally itself, there's a resting muscle tone for all extraocular muscles, resting muscle tone, muscle contraction. Only thing is that suppose 10 impulse is going to one side, the other middle rectus also going to some degree impulse. It's only the relative increase and decrease which matters. What happened during one particular action, when agonist contacts, the impulse of the antagonist decreases. Normally, there's a tonic stream of impulse going. Every muscle is getting some kind of impulse. When the agonist start contacting on lateral rectus, the impulses will go increase there. It will decrease, get inhibited on the other side. That is what is happening in. Otherwise, in the case of lateral rectus palsy, why should the eye go into that action? Because of the unopposed action of the medial rectus. So here also, when the superior oblique is, inferior oblique is weak, there's unopposed action of the superior. Normally in the middle, that the vertical alignment is maintained by the pull of the two muscles. When one is down, the other will overact. That is why the right eye is going in the inferior oblique.
Okay, sir.
and isotropy and athletic response. Okay.
Can do a duction test.
Yeah, exactly. What is it? You should add duction test. Duction test is the ideal thing to find out all restrictive of bodies that should be done post duction test. But there are clinically little difficult for duction test to superiorly. So I have not done that before. Then so let's see how to differentiate the two. In Brown syndrome, there is no vertical deviation in the primary. This is another point you have to keep in mind. If at all present, it is mild. Vertical means downward deviation. In superior oblique, what will you get? The eye will be up. Even the primary position. Last week, I showed a case of the one eye remaining up due to a superior oblique palsy. The inferior oblique palsy, the vertical deviation is there in the primary position and it is large 10 degrees. There's another point. This point you always keep in mind. Superior oblique tendency syndrome is restrictive of the nerve. That fellow has to be relaxed only when that opposite counterpart is put into action, not in the primary position. Inferior oblique palsy is not like that. Always there is some degree of separation and remain even the primary position will be down in the case of a inferior. This is one point which they said. Then another important thing is that it's really difficult for you to understand. Still, I'll make you understand. This is in up case, there is no, but no or V pattern or Y pattern of divergence of up case. There is a looking up, the eyes will diverge. On the other hand, in the case of inferior oblique palsy, the eye will converge. Why I'm telling like that is because suppose imagine patients got inferior oblique palsy. On looking up, the two muscles which are elevators are the inferior oblique and superior rectus. That you know already. When you ask the patient look up, the inferior oblique is not acting. The only muscle is acting is the superior rectus making the eye forward. The superior rectus, the tertiary action of superior rectus is the adduction. The eye goes into adduction looking up. On looking down, eye diverges. That is called the A pattern. The opposite you may find in Brown syndrome, but may not always be. Another important thing is head tilt test. You will not get a head tilt test in case of Brown syndrome. That will be positive only in superior oblique, inferior oblique. Here, if the DD is between inferior oblique and Brown syndrome, so it will be positive in inferior oblique palsy, but not in the case of Brown syndrome. These are the points by which you can differentiate the two. This is the explanation which I already told. Why the head tilt is negative? Brown syndrome is a restrictive orthogonopathy. Hence, even one muscle is fibrosed or affected in restrictive muscle disease, rotation is not possible. The intact inferior rectus cannot act as an extorter because the fibrosed superior oblique tendon will not relax during the external rotation movement, which normally occurs when the patient rotates head to the opposite direction. Okay, I think.
Sir, in this case, his symptoms are for the past 1 week only. Is it possible that he developed a contraction of that muscle within a span of a week? Is it?
No, I'll tell you. Most of the time, the patients, this very often happens in practice. Many of the cases come. You must experience many times by yourself. The child, this has been having in the child for many long years. Nobody will notice. Patients are symptomatic. Child may be having mild health it also. Again, it's a bit since birth onwards, child is having this. Nobody will notice. When some illness occurs and the patient is bedridden, and then the parents become started looking at the patients more closely. Has he got some fevers or other problem like that? Headache, look at that. Then they pick out some head tilt. Oh, this is there for the first time. They pick up very often it happens.
Yes, sir.
Yeah, that's because a thing which has been there from birth onwards will not be noticed by the parents unless someone else picks it up or some illness makes the parents look at closely at the child. This is much as thing.
So, Can you show the signs of Brown syndrome on this patient on looking up and that B and A pattern?
That is not there in this patient. In this patient, looking up, the video 1 second. Looking up that.
Looking up, there's something like a V is there, sir, because it is one.
That may be there, may not be that Brown syndrome, but there is still inferior oblique palsy. But this is not the case of inferior oblique palsy. But that on looking up.
So in the primary position.
Tell me on.
Sir, in the primary position of the right eye, sir, the right eye, if she asks to look upwards, she is not able to look upwards.
Correct.
So can we consider rectus palsy in this patient?
If the patient don't look up, you can definitely consider that possibility. But the clue is that on adduction, on looking up and out, the eyes is able to elevate. I think I will show that once again.
Then can you consider any lesion in the upper orbital apex involving the right superior rectus and superior oblique? That can explain the whole symptoms in this girl, no, sir?
I'm sorry, the reason I tell you. Just 1 minute.
Then it has to be on both sides, right?
One more point. Yeah, I'll start at that level. See this one? Look, she's able to look up and out. Okay, but in the primary position, not able to look up. Now, and also in the adductor position, goes down. That means the problem is in the case superior rectus palsy, the elevation in the abductor position should be weak. Here, the elevation in the adductor position, in fact, it has gone down, going down. So let us say asking the patient to look up and to the left. That's why not be superior rectus palsy. Did you understand what I said? The patient not looking up primary position, it could be either. What you said is correct. More likely both. But here it is likely to be a superior oblique overaction or Brown syndrome.
Doesn't Brown syndrome affect the movement of the right eye when she's looking towards upwards and towards the right? Doesn't that Brown syndrome affect the eye movement?
No, it will not, because the superior oblique has to relax only when the patient the looking down. The superior oblique is an elevator only in the adductor position, not in the abducted position. The abducted position, the action is done by the recti.
And it's in intoter, so it's basically in intoter. So
Yeah.
that will be that may be the reason.
Yeah.
Yes.
Torsion act will be a maximum on the abducted position for the superior. In total, that I think I can teach you that Savala Perivadi, only Perivadi, that audience with the 3 axes, the audience, how the muscles are acting and going the rotate the position of the blow. Can we stop here?
The inferior oblique contractures, the contracture of the inferior oblique muscle, at the primary position, the eye will be normal or it will be deviate upwards and to the medial side, sir?
Usually in contractures, the primary position it will be normal. Only in the eye is put in the position where the muscle is supposed to act or relax, then only separation will come. In the case of a thyroid ophthalmoplegia also, you would not get an overaction of the muscle. It will be in the primary position. When put in the action of that thing, and put in the action of that particular desired muscle action, then only the restriction will become manifest. Because the relaxation needs to occur only in that position.
One more case, sir.
You want okay? One more case. You want ocular movement again or some other case?
Yes, sir.
Yes, sir.
Okay. This is from the YouTube. I took a. Okay. Now, this 18-year-old boy was admitted with the diagnosis of GBS for the last 2 months. He was noticed as some eye problem, which according to the parents developed in childhood following some illness. From birth onwards, child, we don't know. That's the history obtained from the parents. This is the equation. This ILC was after GBS. It was not there before.
Straight.
Look to the left side. To the right eye to temple. Down, there's no downward move. Okay.
इधर
Right eye no object. But what the contrary?
पेन देखा है पेन ओके look at my pen look at my pen okay
Right eye correct.
look down
No downward.
look up
Okay.
okay now मैं इसको आंख बंद कर रहा है मैंने ओके इसमें देखो now this one the deck here down up down up here the deck okay now there's a direction movement. I'm doing the version movement now in all directions either ये पेन में देखो पेन just to go side
The lateral face.
open
Okay. Any thoughts?
So there is the vertical movements are restricted on the right side, as well as the right lateral movement. The medial movement seems to be normal. Left eye seems to be completely normal to me. I'm
Correct.
not sure.
Yeah, you are right. What you said is correct. But right middle leg is also restricted.
straight इधर पेन देखा है पेन ओके look at my pen okay
But do you see that?
Yeah.
Yeah, the middle leg movement is also restricted.
look at my pen
It is restricted middle rectus on the right side. So what is this problem? What is the diagnosis?
Is it something like Mobius or unilateral brain?
The thing he has got third and small stuff on the right side, but not. So it could be either third nerve and sixth nerve also. Okay, pupil is paired. Now, what is etiology? Is it due to some post-infection which has happened according to the parent following a fever in the child? Or is it some other problem? We don't know.
Sir, was there history of diplopia?
No diplopia. So this is instantly detected. He noticed this. He said from birth. Birth means certainly remembers he is there.
Probably there's an amblyopia also. Probably not amblyopia.
Chronic resulted in diplopia. So my question is it congenital or acquired?
I think it is congenital, sir.
Why? Why do you say so?
Because
parent there was a fever preceding that.
There's no diplopia.
But whatever happens in childhood, where it's acquired also may not long-standing, even adult long-standing, the diplopia will disappear. They will not be there. Who is that? The one, I'll tell you the reason. Again, now, what is happening now? See, looking laterally, the right eye is going down. But when not asked to look down, he is not able to look down. Did you see that? See what is happening to the right eye? It is going down. You got it?
Yeah.
What does it tell you?
It's an aberrant regeneration due to an acquired.
That is aberrant regeneration. In Mobius syndrome, you can have easily there will be directional fiber because it's the nucleus, this direction. Some of them may be spared, some of them may be affected. The point reverse is likely to be a congenital etiology rather than acquired etiology. One nerve miscarriage can occur. Remember this point. You can have a pseudo one-grip sign acquired third nerve palsy. Pseudo one-grip sign is that when the patient is asked to look down, the eyelid can go upward. Because of the misdirection of the fibers in acquired third nerve palsy, the fibers which are destined to go to the inferior rectus is going to the LPS. When you look down, you can the eyelid will go up. That occurs, but only misdirection can occur only within one nerve. Do you get my point? Within one nerve. With seventh nerve also, we can get misdirection between branches of seventh nerve. The fibers which is going to the orbicularis may go down. So what will happen if the patient is asking to close the eye? The lower lip will retract, but not in different nerves. Here it is between the sixth nerve and the third, inferior rectus and lateral rectus. That cannot occur with an acquired condition. That means it has to be present from birth. Have you understood what I meant? What you said?
Yeah.
So once more, sir.
Yeah. Now, anyway, you want me to say it again? Yeah.
Yes, sir. Yes, sir.
Yeah, I tell you. Suppose you must have seen chronic Bell's palsy, where the patient had a crocodile tears, so-called inverse Marcus phenomenon, in which patient is asked to chew with or move the lower lip, the upper eyelid will come down, will close. Because when you ask to show smile, instead of the rhizoris contracts, the orbicularis contracts. And you get a ptosis. Just the opposite of the classical Marcus phenomenon. Here what is happening is that when there is an acquired Bell's palsy or injury to the seventh nerve, the fibers which are destined to go to the lower part of the face get misdirected and go to the upper branch and go to the orbicularis. So when ask the patient to show the teeth, the orbicularis will contract rather than the lower part. So you can whenever the patient chews and move the lower lip, the eyelid will contract like a blink. So it will become very embarrassing for the bystanders and they usually looking at the person. That is a case of a aberrant regeneration in the seventh nerve. Similarly, you can have aberrant regeneration in the third nerve palsy, acquired third nerve, for example, a traumatic third nerve palsy, or sometimes even tumors, but not in ischemia. What can happen is that, the third nerve supply the superior rectus, the vertebra superioris, inferior rectus, etc. The fibers which are destined when it regenerates, which are destined to go to the inferior rectus, instead of going to the inferior rectus, get misdirected and go to the levator vertebra superioris. Okay, so what happened when the patient look down? The inferior rectus has to contract, but what happens instead of the inferior rectus contracting, the impulse now go to the levator vertebra superioris. So the eyelid retracts. So what you get, you get a looking down, the eyelid retracts, so-called one-grip sign as you get in thyrotoxic effervescence. It's called pseudo one-grip sign. But that misdirection can occur only within the nerve. If a third nerve palsy is occurring, how can regenerate fibers go to the sixth nerve? That cannot occur.
Yeah.
Somebody has got that kind of a syncline, abnormal synkinesis. We need two different kind of nerves. That means it problem has to be from birth itself. Here the patient has got the abduction is restricted, and inferior movement is also restricted. But asking the patient looking laterally, the fibers which are destined to go to the lateral rectus, that is sixth nerve, get misdirected, has gone down to misdirected, congenitally misdirected, and go to the inferior rectus. So the inferior rectus muscle is supplied partly by the sixth nerve or from the fibers of the sixth nerve. That kind of a misdirection is seen only in congenital. It's very common in even in many congenital skin also this kind of. You can have a so-called A pattern, V pattern of concomitant skins. You can have this kind of a misdirection. And this Mobius syndrome, Duane's infection syndrome is well known. Introduce such kind of misdirection. Apart from the eyelid and the retraction and ptosis occurring in Duane eyelid retraction syndrome, when sometimes the other eye will get overlap. So these are well-known misdirections. I think is it clear?
So this boy can have the third nerve and the sixth nerve involvement both in the childhood. Then he can have the aberrant regeneration. Can show this phenomenon.
No, it is not occur. When it's damaged, the nerve can grow in that nerve only. Only that can get misdirected within the branches of that nerve. But the two nerves are in different locations. One is differently located. That cannot go from one fiber cannot go to the other. In acquired lesions, indicate a miswiring from birth during embryogenesis or whatever you can call. Any questions? Okay, shall we close it for today?
Very nice cases, sir. I'm easy for anything, sir.
Pardon?
I can.
Okay. So we'll go to next Sunday we'll meet. Okay.
Next Sunday, sir.
Sunday. Okay. Any other doubt? Joy, shall I close?
Maybe. Sir,
yes, sir. Thank you, sir.
Where on the start, sir? In between, if you are free, we can do something any other days.
Yeah, please, sir, on Thursday.
Okay, sir. Okay, sir.
Yeah.
All right.
Okay.
Okay, sir. Very good case, sir. Very beautiful case, sir. Thank you. Thank you very much, sir.
Thank you. Thank you.
Thank you very much, sir.
Thank you. Bye.